First of all, I'm very, very excited to be here and to talk about the work that we've been doing for 6 years now. My name is Rob Simmons. I'm Director of Social Services and Public Safety at Oak Park Public Library in Illinois. As I just mentioned, my role started here 2016. And at that time, there was Leah Esquerda in San Francisco Public Library that was providing social work services and clinical services as well, totally integrated into their public library system. And then also at the time, I would say the third most comprehensive model would be in Denver Public Library. So in 2016, we really modeled our libraries, I would say social services model after Denver Public Library, basically because we started out as having a referral-based model. So we currently work with about 41 organizations in the Chicagoland area to be able to provide referral-based services that really focus on housing advocacy, immigration, mental health support, and then also some other clinical supports through partnerships that I'll talk about here shortly. So if anyone is not familiar with Oak Park in the Chicagoland area, Oak Park, Illinois is about 8 miles west of downtown Chicago. And it's located really what is described as, western suburban Cook County. And Oak Park is in a very unique geographic location. So as you'll see, on the screen here, it's a really small, densely populated urban area, even though it's in the suburbs. So it's about 5 square miles, and there's about almost 60,000 residents. It's often described as a affluent community, but it's also a very diverse community, socially, economically, lots of different residents from different backgrounds and things of that nature. And it's a very vibrant community. Oak Park and I would say River Forest, which you'll see on the screen, will be basically described as affluent areas. But Oak Park, both of those communities really have challenges around housing, affordable housing infrastructure, and then also human services and public health access to particularly people experiencing poverty. I would also add that Western suburban Cook County has had a opioid use pandemic, I would say, relatively speaking, for over 25 years. So as you'll see at the bottom southern part of Oak Park, there's been such an issue for about 25 years that they call that 290 highway. They often refer to as Heroin Highway. Austin community is to the right of Oak Park. Oak Park is the first suburb west of Chicago. So Austin, relatively speaking, is one of the most under-resourced and underserved communities in the country. And then there are also other surrounding suburban communities just west of Oak Park that are very small, but also will be considered having a population of mostly lower income residents that also experience homelessness and also co-occurring disorders such as mental illness and substance use disorders. Though, some of those challenging sociological issues, have really over the years presented, unique challenges to public libraries in the area, and then also park districts in the area, particularly because parks are free. You can use those areas for free. Libraries are for free, which is reported from social service agencies and also libraries and park districts in the areas that people experiencing homelessness, particularly with mental health issues, do you utilize those facilities and services for obvious reasons. We actually provide various types of social services and advocacy at all 3 of our branches. I would say since 2016, the top 3 will revolve around, providing advocacy and support around homelessness, mental illness, and affordable housing, and specifically people who are in imminent danger of becoming homeless. Oak Park has about just under 20,000 rental units in town. And believe it or not, there's under 600 affordable housing units. So that is a problem. That is a huge problem. But I'll talk later about a coalition that we participated in currently that is working towards adding more affordable housing units to the area and also mitigating some of the issues around affordable housing. But as you can see, there's various areas in which we identify what vulnerable patrons and families are, who they are. But the top 3 are, we find ourselves advocating around homelessness, mental illness, and affordable housing. I really wanted to point out when it comes to homelessness, there are really 3 types of experiences of homelessness that we find ourselves advocating and working with. The first one is chronic homelessness, and that's individuals that are experiencing homelessness for at least a year or repeatedly while struggling with disabling conditions such as serious mental illness, substance use disorder, or physical disability. And housing advocates will tell you is that advocating and finding resources for people experiencing chronic homelessness is very, very difficult for many reasons. I would say the main reason is that working in a library system, I can't really mandate anyone, and neither do I want to mandate anyone to receive, any intervention that we have or any resources. However, people experiencing chronic homelessness typically are harder to engage with, but additionally with that is, being able to connect them and stabilize them to mental health support and resources, and also housing resources for extended amount of times can be really, really challenging or difficult. But we've done a good job of creating an infrastructure within the past 6 years to be able to position ourselves in our library system to be able to work with partners to stabilize people experiencing chronic homelessness, as much as possible. The second type of experiences of homelessness is episodic homelessness. So these are individuals often with disabling conditions who are currently homeless and have experienced 3 or more episodes of homelessness in the past year. The third is, in this condition of experiencing homelessness has increased, I would say in the past 3 years, is that individuals that are unable to maintain their housing situation and are forced to stay with a series of friends and or extended family members. And Housing of Urban Development, or HUD, unfortunately, they do not recognize doubling up or someone doubling up or a family doubling up with another family member or a friend as experiencing homelessness. So that presents challenges, particularly with being able to locate federally funded support for people doubling up. However, we're fortunate enough to be able to, at least me, work in a state and then also a municipality where we have service providers that can have various resources to be able to help stabilize individuals and families that are doubling up. Since 2016, on average, we serve about 72% of Oak Park residents, and that doesn't include passive engagement, meaning while we interact with, I would say, in any given time in one day, sometimes maybe 40 to 45 people. That's pretty significant considering the small size of our library system. Out of that group or those engagements, it's 70% of Oak Park residents are served. Majority of the cases that we encounter involves Oak Park residents experiencing mental illness, poverty, or that are in imminent danger of becoming homeless. And they also make on average those families or individuals between $12,000 and $15,000 a year. 68% of the services we provide are to individuals, adults, or families with no children, and 32% of services that we provide in advocacy are for people or families with children. That percentage and number has increased also, I would say, within the past 2 years, particularly due to the adverse challenges presented by COVID. So what we've done is, particularly, we had this set up, this continuum. There were 4 elements that I was very intentional about creating to make sure that we had a continuum of care for our vulnerable patrons. The first element I would say is that we really were intentional about providing an outreach program or a referral-based program. So making sure that I was really meeting with a lot of organizations within Oak Park and within the Chicagoland area to make sure that we had sound referral-based services. And we don't refer to just organizations, we refer to people with a first and last name. And we have, worked very hard to build those relationships over the past 6 years. Also, our public safety team, and I'll explain a little more of how this has evolved, at least our public safety model is that when I first started, we had a third party that were providing those services for us, our safety and security services. Our executive director really never liked that model when he first started. I did not either. So my first summer or first year at Oak Park Public Library, the summer of 2016, we decided to hire our own in-house public safety staff, and I'll talk about that shortly. There's 2 fundamental trainings that we do quarterly for our staff. That's trauma-informed care and mental health first aid, which I'll also talk about shortly during the presentation. And fourth element is our strategic partnerships. Our strategic partnerships has really helped us evolve and been a game changer in making sure that really our overall organization, the organization is not socially isolated from things that are happening, decisions that are happening as far as human services, infrastructure, also public health infrastructure, conversations that are happening in the community. So we've done a great job of now being core members, myself and our executive director at Oak Park Homelessness Coalition, which I'll explain and talk about in a few, and also a couple of other task force where we as a library are at the table, and we have a lot of input on any kind of conversations around creating infrastructures or strengthening infrastructures when it comes to human services, and then also social services and public health infrastructure. So, those are really the four elements that create our continuum, and we utilize all four a lot to make sure that we are providing best practice services to our vulnerable patrons. Our outreach program is referral based, which I mentioned. Myself and our public safety team provide outreach to patrons at all three branches. We do not provide direct clinical services. I do, however, as a social worker, provide just screenings and things of that nature with Rush, who provides clinical services to us, and I'll talk about that later. Leah Esquierda in San Francisco, she's been in her role for, I think, 12, maybe 13 years now. They're one of the only libraries in the that has an actually on-site clinician but she works actually through the housing department. It's designed in that way for liability purposes and a lot of other best practice ways when it comes to confidentiality and providing direct clinical services. But Leah has been providing clinical services for over 12 or 13 years in San Francisco Public Library System. Myself and all of our public safety staff, and then we have over, I would say now, 53% of our staff are all trained in trauma-informed care and mental health first aid. And those are two basic non-clinical trainings just to make sure that we don't re-traumatize people and to have a basic understanding, giving, I would say, our first frontline staff, librarians, the tools to be able to identify when someone may be suffering from mental illness, and also the best and safest way to respond to make sure that those individuals get what they need. We also work closely with community partners to connect patrons to resources and support. As I mentioned, our public safety team is really, I'm very proud of the work we've done in the past 6 years to be able to create a comprehensive public safety model. Our manager of public safety is a former police officer trained in crisis intervention training, CIT. So he totally understands and has brought a level of expertise when it comes to de-escalation, but how to properly engage with individuals that may be experiencing acute mental illnesses or also just a traumatic event, particularly in our main branch. Our main branch is centrally located downtown Oak Park, so we get most of our volume of patrons Monday through Sunday at our main branch. So I do, roving and rounds and visit our two smaller neighborhood branches, but most of our public safety staff are stationed at our main branch. Our public safety team provides, once again, outreach and advocacy. And we also just added a public safety and outreach specialist to the public safety team. We really look at our public safety team as an extension of our outreach efforts and our outreach team. And we wanted to move away from a security model where it's monitor and remove. People were following people around, they had badges, things of that nature. We have totally removed away from that. Our public safety staff, they just wear simple polos. It says public safety on them, and they wear just khakis. And we decided to just go that route because, if we were to call for emergency services, police or fire, things of that nature, they're easily identified. And then also they're easily identified for, through patrons and staff if we were to need to call on a public safety person. All of our public safety staff are trained in trauma-informed care and mental health first aid. And then we're going on 3 years now. We have Narcan available at all three branches. So we have right now 43 staff members that are trained in administering nasal Narcan if needed. Since 2019, we've only had to administer Narcan, thankfully, 2 times. So we do have a pretty quick response from emergency services in our community, luckily. On average, if we call, there's a response within 2.5 to 3 minutes. So we're very lucky that we don't live in an isolated rural area where at least emergency services, it takes an extended amount of time to get to all 3 of our branches. So when I first started, I would say that most of our referrals came from just outreach, myself walking around, our public safety staff. But as we begin to train staff on, when it's appropriate to reach out to a public safety person versus a social service person, and then also the longer we've been there, the community, there are just more community members know that we have a social services model and social worker on site. And then, we've really, moved to a space where most of our referrals come from staff, frontline staff in our IT area or another desk where they know the questions to ask, or they know exactly kind of like to determine if that patron needs to be referred to a social worker. 30% of our referrals come from us actually being roving, getting to know patrons, things of that nature. I will say is that my style as a social worker is I don't have a social worker cape on. I don't like just kind of go up to people, in our open spaces and say, hey, I'm a social worker. I think something's wrong with you. And no, like we don't really operate like that, particularly when it comes to people experiencing homelessness. If we notice that someone's been sleeping in a park on a regular basis, or in their car in our basement, or someone tells us that, hey, like we're staying at the shelter and this person may need some additional help, at least we use those opportunities based off of some of the information that we receive for them that will kind of give us a lot of information. We can really would say that it's a high probability that they're experiencing homelessness, is that we then go ahead and engage with that. Particularly, we use that strategy when I first started because, nobody really knew that we had a social worker. But I would say a lot of people in the community in the area now know at least what I look like. And then also is that, if it's not me, it's one of our public safety staff that can get them the resources that they need to get connected to me. But now we have a public safety and outreach specialist that can, fill out a referral form, and then also additionally make the appropriate referral. What I'm very happy about is that we're getting more walk-ins or call-ins, I would say, because of COVID, but there are more and more people from the public that are walking in and specifically asking to see me, which is awesome. I'm very happy about that. So we're continuously doing things from a communication strategy standpoint. There's a social services page on our website, oppl.org, that talks about, just gives you a brief snapshot about all the resources and services that we offer. And then, there are various other strategies through our partnerships where, we make sure that people in the community and surrounding communities know that we have social services infrastructure at all three of our locations. Other is defined as I also get contacted by many service providers in the area. So they just may have, questions of, they may be working with a client. They may be experiencing food insecurity. Can you point me in the right direction? I'm working with a client that may need some resources around immigration support and things of that nature. And I'm able to point them in the right direction. So we really have worked really hard to be able to, provide an infrastructure where our staff can make referrals to our social services and public safety department. Everyone in the social services and public safety department has best practice outreach skills to be able to make sure that we provide those services for our vulnerable patrons. And then also, marketing our program to a point where people know that we are at the library and how to contact us. So we always are continuously working on how we can make sure that, making referrals to our department is easy. This is a snapshot of our referral form. So we do not refer to this form as an intake form. We don't want to imply that we are providing any direct service, clinical services, but it took us about, I would say, really 2 years to create a comprehensive referral form where, there's 2 domains that you see here: food programs, public assistance programs. But there are 10 domains that covers, anything from things like immigration, which I mentioned, homelessness, mental illness, even healthcare resources. And what we've done is we make sure that we, have some resources available right on this referral form. And what we do is, if a patron wants to call directly, we have, due to COVID now, we have a cell phone, so we have a private space that they can call themselves. But also, I'm available just for short periods of time where if somebody needs me to walk and talk them through and actually contact the organization directly for them, then we can do that as well. But this format we found to be most helpful because it really has, and we update this every other month to make sure that all of the resources that listed on the list are current. But that's a snapshot of what's available in the area right away. We also make a copy. I keep it for myself so I can follow up with the patrons. And then also they take a copy away with them. What I also do is keep hard copies in a locked file. And then our best practice follow-up model with our referrals are, I'll call to make sure, I would like to at least contact people, least 3 to 4 times, and that's usually within 2 months after referral is made, to make sure they've been stabilized in that given, whatever the given issue may be. So that's somewhat case management. We really don't focus on case management, but we want to make sure that we're diligent to make sure that if we do refer someone to a resource, that they're getting what they need. And if it's not working, then we might need to, make adjustments and find another resource for that family or individual. We have 2 areas in our main branch, particularly, where we can meet with patrons to make sure, that we can sit down, provide quiet space. It's nice too, because our study rooms are used for various reasons. You can't really hear anything. So we use our study room and then also a small meeting room, which is located on our 2nd floor, and that's a very private space as well. But I'm very conscious about not creating a situation where someone knows that a patron is sitting down and meeting with a social worker. I know, speaking with social workers throughout the country, that having a private space can be a challenge in private spaces to meet with patrons. However, that hasn't really been a challenge, for myself. So there are 4 R's to trauma-informed care. First one is realizing the widespread impact of trauma and understand the potential paths to recovery. And I would say potential paths for us is to provide referrals once you maybe figure out that this person may possibly be experiencing severe trauma. I would say a fundamental key to engagement with trauma-informed care is, particularly if somebody's having a bad day or they're melting down, in the public space, or just hard to engage with, is you don't ask someone what's wrong with you. It's just, please tell me what happened. So that way, I would say, in addition to our public safety staff, we have about, as of the end of December, there was 61% of our staff were trained in trauma-informed care, and I'm able to train them. I'm a certified trauma-informed care trainer. We really walked through pretty comprehensive training and process of even role plays and things of that nature, of saying, not asking people what is wrong with you, but just, please tell me your story. And then from there, there's a way to gather information to make sure that we make that appropriate referral, but also, most importantly, we can de-escalate if needed, and then also don't re-traumatize anybody. Part of trauma-informed care also training is to be able to help people recognize the signs and symptoms of trauma in clients, families, staff, and others involved with the system. Also responds by fully integrating knowledge about trauma into policies, procedures, and practices. So I mentioned the procedures and practices pieces of integrating trauma-informed care through training, but there was a policy that was taking place when I first started around no sleeping. And what that really was doing is that policy was really causing unfair profiling, unfair treatment of people, particularly experiencing homelessness. My question too, when I first started with the no sleeping piece, was, there were some children coming in with parents, and they were like being pushed in a stroller and they were sleeping. So I'm like, are we like applying that same, expectation to children? And of course we wouldn't. So one of the things we did was really looked at areas in the library where sleeping is not prohibited is prohibited because if you sleep at a computer, that stops others from using that particular computer, or in a study room. Those are very high volume entities and spots throughout our library. So we have places where we don't allow sleeping, because that's that stops access to those resources for others. However, if people are at a chair, a table, we are trained, particularly our public safety staff, when they're roving, because we do have opioid issues in our community, is that sometimes we'll stop and make sure we check on people or whatever, particularly if there are patrons where we have identified as having a history of using opioids, particularly on our premises. Other than that, we just redirect someone that is sleeping in a study room or also in front of a computer, is that, hey, here's why, we just rather you not do that here. However, there's, comfortable chairs and tables at other spots, and we direct them there. And, the 4th R is we just don't want to resist. We want to resist re-traumatizing people who are particularly experiencing mental illness, experiencing homelessness, but also just really having a bad day for whatever reason. Our point is to be able to, at all times, be able to make people feel respected and comfortable in our system. And then also, if it's appropriate, when we do need to de-escalate something, we still, have a matter of in the process of making sure that Our public safety staff, we don't handcuff people. We don't put our hands on them. If we do call police, particularly if there's somebody experiencing a mental illness, we always ask for a CIT, crisis intervention trained officer. So CIT officers, that program exists all throughout the country. So we're lucky to have 5 CIT trained officers at the Oak Park Oak Park Police Department. So when needed, particularly if we have someone that's experiencing extreme acute mental health issues, we ask for a CIT officer if available. The mental health first aid training. This helps our frontline staff assess for risk of suicide and harm and how to respond appropriately. Listen non-judgmentally, give reassurance and information, be able to encourage appropriate professional help, which is our public safety staff and myself, and also encourage self-help and other support strategies. We heard a lot from frontline staff, particularly when I first started, but every once in a while now is that, it's very stressful being isolated, particularly if you're at a service desk by yourself. There's someone that needs, a little more than this traditional library services, particularly if they're experiencing mental illness, things of that nature. It can be scary, it can be overwhelming. So this, mental health first aid action plan and training really has provided our staff with reassurance and support to be able to engage with someone and also safely, reach out for help when needed. Mental health first aid is a national best practice training model offered by social services organizations. You should be able to find in your area organizations that offer mental health first aid for free. There was a grant about 2 years ago, and I think they've renewed that, meaning meaning the federal government, of providing funds to have people trained at social services agencies, and then also residential mental health agencies to be able to go into the community and provide those resources. So mental health first aid is definitely a free resource that you should be able to locate and find in your area. If not, you can contact me directly and I can help you with that. Also, trauma-informed care is the same way. There's a lot of resources and service providers throughout the country that provide free trauma-informed care. I can't assume that it's going to be easy, but you can start with maybe some local social services providers, and also to provide maybe some clinical services. And they have trained professionals that would be able to come out to your library system to be able to train in trauma-informed care as well. This has been a game changer for us. And our strategic partnerships, we're able to really provide a lot of different various types of outreach. Also, like I said, participate in and have a table, be at the table when it comes to sharing with other the village managers and other social service providers some of the challenges in our public library space due to the lack of human resource or human services and public health issues that are presented in our library spaces, to be able to share, not only share those experiences, but give feedback and also participate in some decisions when it comes to improving and really just building infrastructure that will help mitigate those issues has been a game changer for us. I'll start with the Housing Forward. Housing Forward is the local housing entity in our area. They provide most of the housing advocacy support in our area. When I first started 2016, I heard that there was a Housing Forward outreach person that we had a great relationship with. But my first 90 days or 33 months there, I had never seen a Housing Forward outreach person. So what we've been able to do is really build a strong relationship where pre-COVID, there was an outreach person at our facility, main branch particularly, Monday, Wednesdays, and Fridays. Throughout the summers, they have a lunch program. So we set up in our vestibule. This is pre-COVID, where there was an outreach person in our vestibule giving out lunches, things of that nature. Since COVID, we did shut down for a little bit, but really we've been back open since the summer of 2020. We still provide some of those services, but a very scaled back level just because of the environment that we're in. But we're still able to provide some of that support. Oak Park Homelessness Coalition, oakparkhomelessnesscoalition.org is the website. But myself and David Sellup, our executive director, we are core members of this group. And it's really we're on our second strategic plan. This is our 4th year in existence. It is not only a policy making group, various work groups within the coalition, and the village manager participates. There are a lot of decision makers, the executives that participate from social services agencies in Oak Park and throughout the Chicagoland area. And then also we have people experiencing homelessness that participates in a coalition as well. There are 4 quarterly meetings that we have, and then various key stakeholders Additionally, attend those, and then also Oak Park residents attend those too, and they happen accordingly. But it's been a great experience participating in such a coalition because, once again, I mentioned is that not only did I see a lot of individuals and families that were socially isolated using our library system that needed social services support, but once again, our library was very socially isolated. It really was a paradigm is that when I started, as long as people experiencing homelessness, have mental health issues, as long as they're at the library, we don't have to do anything. Meaning meaning people who are providing those services, but also other social service providers in the area that were actually responsible for providing some community-based outreach support. So being able to participate on such a coalition has helped us really develop some stronger outreach support for our vulnerable patrons. And it also is not all on the library. So I feel very good about that. All of those community-based partnerships are for free, which is nice. It doesn't entail an additional budget for us, but what it entails is a lot of intentionality behind building those relationships and also being good stewards to the existing resources that exist. So we're going to continue to plug away at making sure we have some great community-based partners. Another really cool partnership was with UIC, University of Illinois Chicago's nursing program. They were on site with some students, I would say this is pre-COVID, 2018, 2 times a week. They were sponsoring a local needle exchange program, but also they had offsite rehabilitative services. So there were about 15 patrons that were connected to that program and received some services, and 3 out of that 15 have been clean for about 8 months now. So I would say that's a win as well. We have a very close relationship, a healthier relationship with Oak Park Police Department, particularly with our crisis intervention trained officers. Oak Park Township, they provide youth services, senior services, and general assistance that we can refer to. And then also Oak Park River Forest Social Services Task Force. That operates similarly to the coalition. There are schools, park districts, other social service providers, decision makers that we meet every 3 weeks to talk about just updates, challenges, and kind of just filling in the gaps of what's needed in the community. And we all work collectively together to make sure that we work together to get people what they need. One of the coolest partnerships we have is with Rush Chicago Medical Center, and we have a no billing mental health clinic. And as of last year, we were able to provide short-term therapy. So this is a free mental health assessment that people can receive, and then also additionally free 6 to 12 therapy sessions. Pre-COVID, there was a psychologist or licensed clinician on Wednesdays from 9 a.m. to 2 p.m. at our main site. During COVID now, we quickly pivoted to a virtual space. Now, of course, we understand that there's a digital divide. Everybody doesn't have access to, hotspots, laptops, things of that nature, but we rent those items out so we can make sure that if someone, is interested in having an assessment, they don't have those resources, that we can at least give them additionally the laptop that they may need with a hotspot, or also we can coordinate on site at our main branch, them coming in and utilizing a technology device to make sure they can get the assessment and also the clinical support that they need. And then lastly, we work with Northwestern University. We're in a 5-year grant to help build a mental health app that will help teens manage anxiety. So we're really excited about that partnership as well. The only partnership on this list that you're looking at, really we had to add in or account for an additional budget for, is our Rush Chicago partnership. And we were prepared for, as an organization, to allocate those funds for that. And we were able to get the hourly rate more than cut in half to receive the clinical services. So that you can't really beat that. And we're really glad that we can provide that resource. We're always looking at, of course, our strategic goals and focus. So we're making sure that our referrals and trainings and anything around the 4 elements of that continuum to support our vulnerable patrons, that we are making sure that our engagement strategy is sound. We're providing learning opportunities, which comes through the trainings, being very good stewards of resources that we are utilizing, and also prioritizing equity, which is most very important, making sure that everyone that walks through our doors, if we cannot get them what they need, we can point them in a direction to get our patrons what they need. Of course, there's quantitative data that we look at on a regular basis. And we use our whole organization uses program logic model as one of the qualitative data tools that we look at as far and use as far as a measurement and evaluation tool. It's not the only tool. Of course, we use surveys and various other things to make sure that we, are measuring and evaluating everything we do. But, the program logic model we're really looking at least in my department particularly, is short-term goals and strategies around if we're, having an impact around changes in knowledge, skills, or attitudes about an expected program, what changes in behaviors or actions is expected from the program. So looking at, some of the clinical services and resources we need or we provide to make sure, that there's a change in behavior. We track that. We work closely with Rush and their data people too, to make sure that we can articulate and track movement and stabilization. And then also what changes in status and condition do we expect from the program. There are some really cool trainings that we utilize. I've mentioned the mental health first aid and trauma-informed care, but the California State Library Services has a Welcome to Mental Health initiative. It is available on YouTube. I think it's 6 or 7 series, and it is awesome. It shows a lot of role plays around how to engage with people experiencing mental illness, and then also shows some role plays around how to respond to patrons or the community that says, why are those people in our library? Like that's, we shouldn't have those types of people, particularly people experiencing chronic homelessness and things of that nature. So it's a really good series. It's for free. It's on YouTube, and we utilize that for some of our professional development resources in our library system as well. I hope that was, helpful. Like I said, I have contact information available. The slides are here, but please reach out to me additionally via phone or email, and I'll, be able to support you and provide you with as much resources as I can. Thank you.